Hi, good morning. I'm Vincent, anesthetist from Queen Elizabeth II Hospital, Kota Kinabalu, Sabah. I'll be talking on the ventilator modes and strategies in ICU today. All right. So the content of the talk today, basically I'll start off the basic of the mechanical ventilation, and subsequently talking about some common ventilator modes in ICU. Then move on to ventilation strategies for common diseases in ICU, and we conclude it with the closing remarks. My slides later on are mainly pictures. They are not busy. There will not be a lot of words. Okay, the mainly is to show you guys the overview and also the general principles of mechanical ventilation in ICU. All right, when we are talking about the mechanical ventilation, so we're actually referring to the support of the respiratory system, okay, when the respiratory system fails. So as you can see, there's some volumes and also capacities that's important during our spontaneous ventilation. So what's the difference between the spontaneous and mechanical ventilation in terms of the lung mechanics? Okay, the above picture shows that it's a spontaneous ventilation. So what happens to the pressures inside the lungs, okay, during a spontaneous ventilation? In a spontaneous ventilation during inspiration, the intrapulmonary pressure and the intrapleural pressure both are negative. Okay, so this is to suck in the air from the atmosphere into the lungs. All right. And how about the expiration during a spontaneous ventilation? All right, because of the passive recoil of the lungs, all right, so the intrapulmonary pressure will turn positive and the air can be expelled from the lungs to the atmosphere. But it happens the other way around for the positive pressure ventilation. Okay, because of the generation of the positive pressure by the ventilator, as you can see the graph below, both the intrapulmonary pressure and intrapleural pressure returns very much positive. As you can imagine, the air is actually pushed in through a positive pressure by the ventilation into the lungs, rather than the spontaneous where the air actually is sucked in because of negative pressure. All right, during the expiration, it's actually almost the same because it still occurs passively. All right, because of the lung recoil, so the air can be actually pushed out back to the ventilator and be scavenged. Okay, in anesthesia, we always talk about this. Okay, as long as the air can goes in and out and the blood can goes round and round, actually we are quite safe. Okay, as the saying goes lah. All right. So talking about air goes in and out in terms of ventilation, all right? People may be thinking how hard it can be, right? Okay, only those who actually handle ventilation can know that, okay, can know actually how hard it can be. All right, so there's some pictures showing the mechanical ventilators actually evolving from ancient type to the modern type, as you can see here, right? The above picture is the sort of the old ventilator, very ancient type of ventilator. It's the minute volume divider, and subsequently it has actually evolved into a very beautiful, as you can see the bottom picture. All right, it's a modern ventilator. But anyhow, the principle is still the same. All right, they are actually meant to replace or supplement the natural breathing at the appropriate volume. And how it actually works, it works by the mechanics of the generation of the inspiratory forces, and subsequently the control variables and the phase variables simply means that how the breath actually is going to be delivered into the patient, and that's actually controlled by the operators. All right, so if you are a fan of Marvel, you will surely knowing this is a first generation of Iron Man suit. Okay, it's Mark 1. All right. Okay, I want to show you this because the subsequent slides will be actually quite similar to this iron man suit because it's called an iron lung. All right. So this is the first generation of a ventilator where they actually try to mimic the normal respiration by creating a negative pressure inspiratory forces, but subsequently has been replaced with a positive pressure ventilation. And this simple diagram, just want to show you guys how the inspiration actually started as a positive pressure ventilation from the ventilator. And as the air goes in, the lung expands, the diaphragm contracts, and the intrapulmonary pressure turns positive. And again, the expiration, the latter one, occurs passively from the lung recoil. We move on to the control variables. All right, so control variables are actually playing around the three variables, that is the pressure, volume, and also flow. If you recap back what you see in the interface of the ventilator, actually it shows that this three waveform as well, right? The pressure, volume, and flow, all right? And actually it goes according to the equation of motion, all right? Just want to show you guys the volume ventilation and pressure ventilation. Okay, forget about the formula, but just want to show you guys, if you are doing a volume control ventilation, as the name itself, the volume control means that we control the volume, but we have to see the pressure that's actually delivered. All right, it's actually counter check each other. It's just like you fix the volume and the flow, but you have to check the pressure whether it's appropriate or not. The same goes to the pressure ventilation. Let's say a pressure control, we fix the pressure, and then after that we have to check whether the volume is adequate or not. All right, so it's just counter check each other. And this is the picture of the interface from a ventilator. All right, the pressure is always on the top. Okay, subsequently you can see the flow and the volume. All right, just have to show you guys how it actually appears, these control variables in the ventilator. Okay, how about the phase variable? What is phase variable? It basically simply means that how the breath, the process or the phases that the breath goes through from inspiration to expiration. It divided into 4 phases. Okay, start off the inspiratory trigger. Okay, the triggering must have a trigger. All right, whatever trigger is it, can be pressure, can be volume, can be time. Has a pressure, it must have an inspiratory trigger. Then inspiration to the limit that we set, to the maximum limit that we set. Then subsequently, when is the cycling from the inspiration to expiration and subsequently expiration, whether to baseline or to the peak that we set. All right, so these slides just want to show you the few triggerings that actually from the ventilator that we set. It can be pressure trigger, it can be flow trigger, it can be time triggered. All right, so if a pressure trigger, you can see there's a dip in the pressure. All right, the trigger there, you can see a trigger here. There's a dip in the trigger because the patient started to have a spontaneous effort by taking breath spontaneously. There will be negative pressure because the patient is sucking in. All right, so there will be, after, if the machine detects the trigger here, it will deliver the breath. If you put a flow trigger, it means that if the patient has a spontaneous effort, the flow will be increased based on the patient demand. If there's an increase in the flow, the machine detects it and you deliver the breath, right? Just different types of triggering, different type of detection. And if it's time triggered, as the name is time triggered, doesn't matter what is it, okay, according to time, when the time comes, the patient triggered, that's all. Okay, so we move on to some basic ventilator modes and features, but before we move on to ventilator modes, there are actually few types of breath that we have to know lah. All right, so a control, assisted, and spontaneous, that are the 3 main types of breath. All right, it displays around these 3 main types. For control, or it called a mandatory ventilator, it's called mandatory breath, sorry. All right, as a name itself is a mandatory, it's a control. All right, so that means it's fully controlled by the machine. Okay, by the machine, of course, based on the setting that we set. All right, it just deliver according to the setting, the timing that we set. And an assisted breath, what it simply means different, what is difference actually from the control breath. Assisted breath basically is considered under mandatory here as well, because whenever there is an inspiratory effort, all right, during the respiratory cycle, the machine will deliver the breath based on the setting that we set, all right. A controlled mandatory ventilation simply doesn't support or doesn't actually meant for spontaneous breathing patient, all right, as it only goes according to the setting and the timing that we set. But for the assisted breath, that means if the patient, as long as the patient got inspiratory effort and the machine detects it, it will deliver a full support, a full breath. For example, if you set a tidal volume of 500, it will deliver 500, even there's a small inspiratory effort that the machine detects. So if the patient breathing at the rate of 18, for example, or 20, there will be a 18 to 20 of a full assisted breath, all right, based on the tidal volume that we set for the patient, all right. Hope you guys can imagine that. All right, a spontaneous breath, okay, name itself also is spontaneous, means that it's all fully by the patient, all right. The volume, the rate, all right, is all by the patient inspiratory effort. What are the common modes of mechanical ventilation in ICU? All right, it can be divided broadly into 4. Of course, if you're counting another, actually can be more, but then I put in 4 here for better understanding. All right, I'm not going to talk on every of the modes, other modes other than these slides. All right, because there are few more other modes quite sophisticated, and they are quite new also as well. But these are the modes that we commonly encountered. All right, so it can be a continuous mandatory, where it's quite CMV, continuous mandatory ventilation. Can be an assist control. ASC means assist control ventilation. So these are under the continuous mandatory ventilation. And if it's continuous spontaneous, okay, simply means CPAP or pressure support ventilation, PSV. And we also, I think, quite familiar with the mixed mode. There's SIMV, synchronized intermittent mandatory ventilation. There's bilevel and also EPRV. And another one is called dual modes, I would say. It's called PRVC, pressure regulated volume control, or another name for it is a VC plus in certain type of ventilator brand. All right, it's a Puritan Bennett. Okay, so we talk on it one by one. So for CMV, continuous mandatory ventilation, what it simply means here is that, all right, it delivers only the control breath. Okay, it can be pressure control, it can be volume control. All right, we're using the paralyzed patient. All right, as you can see here, because patient will be dependent solely on ventilation, and we actually don't really want a spontaneous effort or spontaneous breathing during a controlled mandatory ventilation. All right, because patient will be simply fighting the ventilator modes. All right, so the waveform or the picture beside simply showing you that there's a volume control and the pressure control. Okay, the volume control is a time triggered. Okay, I think everybody knows to set the timing, right? Respiratory rate is your timing. How often you want the breath to be delivered. All right, and there's a flow limited as well. Okay, we're also setting the flow, and it's a volume cycle. Every time it reaches the volume, it will cycle off. It just means that cycling. Remember the cycling from the inspiration to expiration. All right, that means how it actually the cycling basically the cycling basically happens when the volume is actually reached lah. All right. So for example, you set a volume of 500. Whenever the volume reach 500, it will cycle off. It will cycle off from inspiration to expiration. And for pressure control, it's a time triggered again. All right. There's a respiratory that you set, and it's pressure limited, because you are setting a pressure control of how much, 18, 12, something, right? So and then it's time triggered. This one is time triggered because you're setting in a pressure. It will reach the pressure that you set, and then subsequently it will cycle off based on the time. All right, the timing of the setting that you set. All right. And I put here this, can see a asterisk here of valve status. What do you mean by valve status? We are explaining it in the later, this one, the next slides. Okay, so why we are saying that a CMV is for paralyzed patient? That's why you see CMV most commonly utilized in the OT setting rather than the ICU setting. ICU, I mean, very, very less, very, very infrequent. You will see this kind of setting, right? All right, because it's meant to be a winning place. I mean, ICU, you don't encourage patients to be paralyzed all the time. Right, so what it meant here, the valve status is that, okay, you can see during the inspiration or during the generation of the positive pressure, when the patient tries to inhale more gas, the ventilator is willing to deliver because it's open, the valve is open, the inspiratory valve is open, all right? But what happens in between of the breath, as you can see the middle part there, the patient when tries to initiate a breath in between the breath, right? The ventilator actually can't provide you a breath because the valve is closed, the inspiratory valve is closed. So the pressure is there. You can see a dipping of the pressure because the patient is breathing, is having spontaneous, but there's no gas delivered. So it will be increasing the work of breathing. Patient will be very uncomfortable, all right? And you can see the patient try to exhale. What happens if the spontaneous effort occurs during the positive pressure, during the expiration, where the patient is going through expiration, all right? It will generating a positive pressure there, but then the ventilator keeps the expiratory valve closed, all right? So it can't breathe out also as well during the inspiratory breath. So it's very, very non-physiological, all right? So that's why it's only meant for basically for paralyzed patient or patient really without a spontaneous effort. We move on to assist control SC mode. So what's meant by SC mode? An SC mode actually allows a triggered breath, like I said earlier on, and then the breath will be assisted. All right. And SC mode, if you paralyze the patient and put on SC mode, actually is similar to CMV. In nothing much will be actually is no difference at all. All right. The idea or the advantage is to provide a full ventilator support in a stable respiratory drive patient. All right. Okay, so what you can see here, it actually okay. What happens actually is that basically if the patient has a spontaneous effort, for example, you can see here there's a dipping in pressure. The breath will be supported fully. What I mean here fully is that let's say you set the mandatory mode of tidal volume of 500 at a rate of 12 or something. So every 6 seconds, or this one, all right, 5 or 6 seconds, they'll be delivering on the breath. But let's say this patient has this one triggering effort, okay, have a inspiratory effort, okay, in between or throughout the 1 minute, all right, the machine will detect it and give out a volume of the same control breath volume, okay, the 500 that you set early on, all right. So you can imagine if the patient has a respiratory rate of 20 or even more, all right, and the patient has a strong respiratory drive, all right, the machine will detect the total of the 20 of the respiratory drive, of the respiratory effort, and deliver a full breath according to what you set. You set 500, you get 500. So got a 20 of a tidal volume 500 throughout the 1 minute. So what happened? All right. So it comes to the subsequent one here, the complication. It can cause hyperventilation. So much of volume that you're delivering based on the patient effort. Patient got more effort, the more you deliver. So what happened? Because hypocapnia, respiratory alkalosis, and of course, in some certain cohort of patient, you get autopic lah. All right. So that's, I'm not so sure in a lot of centers, all right? But if you are in my center, probably in other places, I don't know, but then I didn't see a lot of practices using SC mode, all right? I'm not a fan of SC mode as well. I hardly use it, all right, because I don't like it, all right? But of course, some centers do like it lah, all right? Okay, so we move on to the continuous spontaneous mode of ventilation. Common one is CPAP, okay, as continuous positive airway pressure. Okay, so what it meant, it just give a PEEP, all right, continuous PEEP throughout the inspiration, expiration. But the whole thing, the respiratory rate, tidal volume, inspiratory time is all determined by patient. Basically, it's a spontaneous mode lah, okay, and everybody knows it's common for weaning, all right, and what actually does that is actually improve the oxygenation and prevent the atelectroma, the atelectasis, right? A pressure support ventilation. A pressure support ventilation simply means that actually combination of like CPAP and with a pressure support. Okay, you do have a PEEP there, but I put a bit of pressure support to improve or augments the spontaneous effort, all right, of the patient. Let's say, for example, if you think the patient is not having a very good spontaneous effort yet, okay, as evidenced by inadequate tidal volume, we can put on a support so it can be supported to the tidal volume, all right? And as time goes, patient gain more respiratory muscle effort and more stronger in terms of respiratory. So it will be reaching a stage where you can actually cut off the support, all right? Same goes for weaning and basically to reduce work of breathing, right? All right. Okay, so we move on to the some common ventilator modes in ICU. There's SIMV. Okay, synchronized intermittent mandatory ventilation. I think this one is quite common in our setting here. All right, and probably a lot of places also as well. Okay, we are quite familiar with this one. It can be volume control, it can be pressure control. Okay, why you call a mixed mode of ventilation? Because it's combination of a mandatory and also spontaneous ventilation. Okay, where the spontaneous breath actually is allowed during a synchronous period. All right, and if the breath occurs during the asynchronous period of this mode, okay, the ventilator just simply deliver the control breath lah. All right. The good thing is that it avoids the breath stacking and also commonly used in weaning, all right, before a CPAP. All right. Okay, so this slide basically shows you the mechanics of SIMV. It's quite complicated actually, but then you just understand it in the way that, all right, you can see that as a TM. T means time, okay, the interval of the mandatory and interval of spontaneous, all right. So it shows that when the time of the mandatory interval, it actually reserved for the patient-induced mandatory breath, all right. And the spontaneous interval actually, the VIM means that the ventilator-induced mandatory breath, all right. That's delivered if there's no patient-induced breath during the TM time, during the mandatory time, all right. So it simply means that you can see the TM there is actually the synchronous period. The synchronous period, all right. It's kind of confusing because the name itself, I'm not so sure why it's called a mandatory interval, but it's reserved for the patient-induced of their breath. Whereas for the spontaneous interval is actually meant for, it actually means that the ventilator will induce a breath, all right. So for me, it would be better if they interchange it now. All right. So, but then it's something like you can see below here. If there's no effort, no spontaneous effort, okay, this one patient-induced mandatory breath during the TM time. All right. So the ventilator-induced, okay, will be given at the end of the synchronous period. All right. That means if the patient, if the machine detects there's apnea happens, okay, you wouldn't let the apnea prolong. Okay, it will deliver a breath after the synchronous period of time to at least guarantee a breath that you set, okay, mandatory breath that you set, okay, to the patient. But at the same time, if there is a spontaneous effort during the PM time, it will get supported. All right. Okay, this graph just simply means that, all right, you can see some spontaneous breath. It can happen throughout between the two mandatory breath. All right. So we move on to bilevel. So bilevel is also one of the mixed type of the mechanical ventilator modes. All right. So it consists of the mandatory and spontaneous as well. All right. The mandatory is pressure control. And of course, spontaneous means it can be supported like pressure support. All right. As the name itself is bilevel, means there must have two levels. All right. There are two levels of positive pressure that you can set, namely is the P high or P low, the PH and PL. All right. P high and P low. And if you have P high and P low, means that you must have a two timing also as well. So you have the P high and P low. So you have four parameters. Okay. The T high, okay, I put a star there. You can see an asterisk there of the inspiratory time and expiratory time. Actually, it's a misnomer. It's a very confusing things if you really fix your mind into the inspiratory and expiratory time of a T high and T low respectively. Actually, it doesn't mean that way sometimes. Or you can get really confusing if you fix your mindset as a inspiratory and expiratory time. Okay, later I'll be explaining. All right. Okay, you see the graph here is a spontaneous breath. Okay, this is a P high and P low. I think you can guess it. One is high, one is low, right? So one is the pressure of the high, the P high that you set, one is the pressure of P low that you set. Can you see the spontaneous effort there? All right. So it simply means that actually the patient is breathing spontaneously at the two level of pressure that you set. Patient can breathe spontaneously. So that's why I'm saying that if you fix your mind that the TH and that the T high and T low means that inspiratory time and expiratory time, you get confused. You'll be confusing why in inspiratory time then a spontaneous breath can occur. How I'm inspired means that I'm actually taking a breath in. Then how can I actually still spontaneously breathing when the time I'm just taking a breath in? You understand what I mean or not? And during expiration, how can the spontaneous breath actually occurs? It actually doesn't make sense, right? If you put it as inspiratory and expiratory time. So make it simple. It just means that at two level of pressure that you set, okay, where the spontaneous breath can happen at the two level. All right. The bottom picture actually is better. All right. You can see it actually means that during inspiratory phase, what we call inspiratory phase as general, because we're actually recruiting the lungs. There's a positive pressure. Just imagine that you are taking a very deep breath during that time and maintain it for some time. All right. But the good thing about this bilevel, it actually allow a spontaneous breathe in and out during the inspiratory time. All right. And the expiratory time, we normally call it a release time, a release phase, all right, where the gas actually scavenge out, okay, it's releasing from the lungs, and before the next breath can happen again, the next positive pressure can happen again. It can't be positive pressure all the time. If it's positive pressure all the time, it'll be like CPAP lah. All right. So this is a bilevel. All right. You can see here bilevel. Just now the graph shows the same also as well. Okay. But what is APRV? Just to bring you guys to what is APRV, airway pressure release ventilation. You can see the graph actually is pretty much similar, but just a longer, very long. Okay, just a longer P high. All right. So this is what APRV is. Right. So the APRV is a time cycle prolonged. Okay, time cycle, you set the timing there, all right? Prolonged high positive pressure, a very high positive pressure probably, okay, and a very long timing, and only interrupted by a brief period of pressure release. Okay, we don't call it an expiration, but call it pressure release. You got to release the pressure as well so that the gas can be scavenged out and providing a subsequent breath again. All right. So it's a rescue therapy normally we use it as a rescue therapy for severe ARDS. All right. And the pH here dictates the P plateau. All right, you can see a pressure. Let's say I put a pressure of 30. All right, and because most of the time the breath is at the high P high, at the pressure of the high pressure that you set. All right, so this is how we determine the TLO, the timing of the TLO. Okay, we must be brief enough, but shouldn't be too long. Okay, as it will actually leads to atellect trauma. So how we actually determine the TLO is basically through our PEFR. Just have to measure the PEFR. All right, and 50%. Right, 50% is around here. So that's our TLO. All right, just have to see the timing. All right, the timing, everything, and touch on with 50%. Right, when it's 50% of PFR, it's around here or something. Yeah, so then that is our TLO basically. All right, so that's optimum TLO. But right, every time you do APRV, you should you should calculate it lah. Calculate the TLO. But then most of the time the TLO lies between 0.4, 0.6. Yeah, so that's why safely we just put at 0.5. I mean, yeah, it's a spinal reflex lah. So it shows this table shows differences or summary between the conventional inverse ratio ventilation bilevel and APRV. Just want to show you guys the bilevel and APRV. Bilevel basically put on the IE time of 1:1 or slightly longer, so okay, about 1:4. For the APRV, it's a very inverse ratio ventilation, can be up to 9:1 is the true APRV. All right, so you can see the mean airway pressure is very high in APRV. Okay, owing to the high plateau pressure that we show early on. Okay, because of the prolonged P high, and a spontaneous breathing you can see here is actually they're promoting a free breathing. All right, spontaneous breathing for the bilevel APRV, and the auto PIP also is quite high in APRV. That's why we don't use it for certain cohort of patients, for example, obstructive lung disease. Okay, mainly used for the atelectasis patient or ARDS patient, but the lungs is collapsed. All right. So people may ask me why when do you use bilevel, when do you use APRV? Bilevel actually most of us are not very familiarized with bilevel because we hardly use it. Okay, because it's human nature. When we use APRV, it's also when the time of severe ARDS. Okay, we are too used to the practice of if it's able to be ventilated using a conventional ventilator modes. Why you want to change to something else, right? When you can ventilate, we only do things when we only change when things get out of control, things get out of hand, already come to a severe stage, then only we come to a salvage therapy lah, or like APRV. So ideally a bilevel actually can be used, okay, but bilevel should be used in the early phase of ARDS or when the PF ratio, okay, doesn't comes to a very severe end yet. All right, so when it comes to severe end, we use a bilevel, commonly actually it doesn't really help lah. All right, okay, the severe ARDS should be using APRV. All right, a bilevel normally can't really bring up the saturation, can't really improving the ARDS because it's meant for early stages or probably some other pathologies, some other some other lung diseases that you want to promote a spontaneous breathing, but at the lower at the non severe kind of case. All right, just that we are not familiarized because during this level normally a conventional ventilator modes can be supporting. All right, this diagram simply wants to show you guys there's a zone of atellect trauma and the zone of volume trauma. All right, so the idea to ventilate actually is this safe window here. We don't want to go to a zone of volume trauma and zone of atellect trauma. That's what APRV does, but APRV does it in the inspiratory limb. All right, it manipulates the parameters in the inspiratory limb. Sorry. All right, so as you can see, the high plateau pressure at high inspired pressure. All right, to recruit back the lungs. Okay, by the form of high plateau pressure during the inspiration. Right, whereas the HFOV, the high frequency oscillating ventilator, okay, does it in the other limb, that's expiratory limb, because it combines the high oscillating forces to bring out the carbon dioxide to facilitate the expulsion of carbon dioxide from the lungs. Okay, at the same time also providing a very high PEEP because it's high frequency, small tidal volume, but a very high PEEP. I'm not talking about in detail of this HF4V because it doesn't actually it's quite rare. It's not actually readily available in all centers lah. All right. Come to PRVC, and also another name of it is VC plus for the protein Bennett. So it's a volume targeted pressure control where the ventilator adjusts the pressure breath to breath. All right, it has to compare the tidal volume with the set tidal volume, then adjust the inspired pressure on the next breath. So the good thing about PRVC is that it always uses the lowest possible pressure to attain the preset tidal volume. All right, so it's some sort of like the ventilator is quite smart. It uses the adjust the pressure and uses the lowest pressure to attain the tidal volume that you want, of course, based on the patient demand and also lung compliance. But the bad thing about it is that if the demand increases, all right, or demand increases, or lung compliance actually increases, lung compliance actually decreases. So the pressure control also can the pressure control also can decrease. But let's say for example the patient is tachypnic. All right, the ventilator will perceive as the patient is improving, as the tidal volume is improving. But the thing is that, but the fact is that patient actually needing more support. But at this point of time, since the tidal volume has increased when the patient is tachypnic, all right, so the pressure control will be reduced. So the patient will be like suffocating, right? Doesn't have the enough pressure control to support the breath. Okay, so another thing is that it needs a number of delivered breath to achieve a tidal volume. It doesn't change swiftly. It needs some adjustment, some few breath to come to a full adjustment. Okay, what we show here is that you can see here if the maximum target change in the pressure, all right, when the breath is less than 5 breaths, the target change will be higher because you want to achieve the tidal volume that you set, and so that the pressure have to be changed more drastically. You can see like up to 10 centimeter water, all right, 10 pressure. So after 5 breaths or more, so actually the change in the pressure will be just plus minus 3 cm water, right? So if there's a sudden change here, the ventilator couldn't respond very fast, swiftly into the change. So it takes more time. All right. So we move on to the common ventilator strategies in ICU. So the most common one that we utilizes for most of our patients is the lung protective strategies. All right, this ARDS net. Mainly we use for ARDS patient. All right, of course can be used for other cohort of patient as well. All right. So I think everybody sort of like actually quite familiar with this mode. All right, we have been using it quite a lot. Okay, so we have to find the predicted body weight and always we use the minimum tidal volume as possible. Okay, 6 mL per kilo per body weight. Then keep the plateau pressure always less than 30 to prevent barotrauma. Okay. And also using high PEEP, okay, appropriate PEEP, optimum PEEP to prevent atelectrauma, all right, permissive hypercapnia and all these things, right? Okay, I think you guys knows about this. This is the most common one. And the second one come to a cohort of obstructive lung disease, all right, like for example asthma and COAD. Okay, since it's obstructed lung means that okay, there's a ideally you should be thinking of a very problematic in exhalation. Needs a very long time to exhale. Patient might be having a very severe bronchi, all right? Severe bronchi, like for example in the ACOAD or AEBA. Okay, the ventilator setting ideally we prefer volume control setting. The reason being because pressure control, if the spasm break, then the pressure actually, if it's not detected immediately, then we deliver a very large tidal volume. All right, it can subsequently lead to barotrauma. So we use a volume control despite higher plateau pressure or higher mean pressure, mean airway pressure, but we just have to prolong. Normally we prolong the expiratory time. All right, to let the lungs to give time for the lungs to expire fully. Okay, we use a lower expiratory breath, okay, so that the P plate wouldn't be so high, and a small tidal volume, all right, a small tidal volume, and a high inspiratory flow to wash out carbon dioxide. All right, you can apply a bit PEEP if the patient is breathing spontaneously to compensate for the intrinsic PEEP. But if the patient is sedated and paralyzed, so a zero PIP actually is advocated, right? So for a cohort of a bronchopleural fistula, so of course the best is a one lung ventilation. Okay, logically, if the site there's a pleural fistula, bronchopleural fistula, you may want to rest the lung. Okay, the best thing is to isolate the lungs, let it rest, and then you only ventilate one lungs. But then come to ICU setting, we all know that the double lumen tube or one lung ventilation is not really suitable to be ventilated in ICU setting, okay, due to the problems of like suctioning, pressure necrosis, all right, dislodgement because of the heavy tubes, and probably some ventilator as well that will be not compatible sometimes. So all these things are hampering the use of the one lung ventilation in ICU. So the whole idea is that we have to rest the lung. Of course, if we're talking about the fistula, then it's actually feasible to be closed by itself, spontaneously healed by itself, probably a small fistula. But if talking about big fistula, then forget about it, all right? So then have to, no matter what is it, have to go for surgical intervention. You know that it's so big, it can't really heal by itself, then forget about it, then better refer for surgical intervention. So for we are talking about mechanical ventilation strategies for this cohort of patient. So the idea is to reduce airway pressure by using the lowest tidal volume, lowest speed, short inspiratory time, and reduce minute volume or respiratory rate. All right. And if there's a pleural decompression device or this like chest drain is there, right? We use a lower suction or no suction at all, right, to prevent flow. All right, the whole idea is try to minimize the flow across the fistula. All right, because a positive pressure, especially a flow across the fistula, it will be slower to heal. All right, and allow spontaneous as tolerated. All right. Okay, so before we end, we'd like to talk about this ROX ICU trial. Okay, that's our site here is practicing. All right, so it actually done in Australia and New Zealand by 2019, about 900 patients. It compares the usual oxygen therapy that we always used last time, okay, and the conservative oxygen therapy. All right, it compares basically. Last time we always use oxygen no less than 0.3 FiO2, right? All right. So here basically it compares the FiO2 lowest as possible, as closer to room air. Best is room air, 0.21% of FiO2, to the one that we always use earlier on that we seldom reduce it to FiO2 less than 0.3. Okay. So what they found out is that during the first 28 days in ICU, all right, comparing the conservative limb and also the usual oxygen limb, all right, actually did not significantly affect the number of ventilator free days. So that's why we employ what we employ here. If the patient lungs is okay, if the patient lungs has no problems, so normally we go lower than 0.3. Okay, some even tolerate under room A. Okay, so this is the protocol that we are doing in our ICU. It's conservative oxygen therapy. So what happened? We have to get to the region. I want to get to the region of this green part here, just right. All right, just right. So if the SpO2 is more than 97 or more, all right, it's too high. All right, you can see here it's treated as emergency. All right, it's a bit exaggerated. All right. So the idea is that if the SpO2 is good, all right, and it's more than room air, okay, we reduce the FiO2 by 0.1 at the interval not greater than 5 minutes, all right? So every 5 minutes now, right? Or 5 minutes, if the SpO2 is very good and the FiO2, let's say for example, now it's 30, you can reduce it by 0.1, all right, 0.1, okay, for example, higher, sorry, not 0.3, higher, you reduce it until 0.3, all right, and then further down again, until the SpO2 probably less than 97. The target we use is 91 to 96%. All right, is acceptable. Okay, so anything more than 92% acceptable lah. All right, so we use lowest FiO2 possible to accept to achieve the acceptable SpO2. So if the FiO2 is more than 0.1, All right, now, but less than 0.3, for example, it should be decreased at least 0.05% lah, okay, at the interval of 30 minutes or less until the FiO2 is 0.21. Okay, and of course, if the SpO2 is already falls below the target range, we have to increase it back to the previous FiO2 that you can attain a good SpO2. Okay, then after that, only try to wind down again. Okay, so we come to a conclusion. This is a closing remark. All right. The most dangerous phrase is that we always thought we have done it in this way. All right. That shouldn't be the way. It serves as a reminder for me and for all of us. I think we always, some sort of time, always have come to this phrase. We always practice it also as well. All right, because we are comfortable with it. We always say in our center we do it this way. Myself, I always do it this way since how many years ago, I think. But you must understand that actually things have evolved lah. All right, there's a lot of new things and new knowledges. All right, and patient cohort also is not the same every time. All right, everything has been done tailored to case-to-case basis, and we always have to practice evidence-based medicine lah. All right, so try to get away from this kind of saying that it's always done in this way. So yeah, we just do it this way, then nothing can go wrong lah. All right, probably yes. I mean, but then it wouldn't be the best for the patient sometimes, right? Okay, with this, I conclude my presentation. Thank you very much.